Hey everyone, this is Tony from TRW Medical. I'd like to talk a little bit about NRP, neonatal resuscitation again. Before we begin, let me just tell you that I'm old school, and I've taught the NRP for many, many years. And I have been to, I've been a transport therapist, which means we go to other facilities, we stabilize the infant, with airway IVs, put them on vents, and after stabilization, we ship them to our facility, where we have more modern advanced, like jet ventilation or that kind of thing, or oscillation, And, respiratory therapists, we have to attend all high-risk deliveries. So, for many years, the NRP would recommend for a non-vigorous infant, visualization of the cords with a laryngoscope, right? You visualize the cords, and then you insert an endotracheal tube in a non-vigorous infant, and very, very quickly suction the meconium out below the cords and around the cords within, 5 or 10 seconds. And I'm here to tell you that that is a lost skill. So yeah, I have a little bit of a beef with this new NRP 8th edition with that, because I know that lots of times, you get infants that are even vigorous and they're just covered with meconium. Or maybe, they have a ton of meconium in their stomachs that they've ingested. And after birth, you take them to the NICU, you take them to the mom, they have distended abdomens, or they have reflux, and then this meconium comes up and they aspirate it, and then they end up having issues and problems. And sometimes it's a lot of serious problems, So, when I attend a delivery, if it's a shame that they don't advocate or at least say somewhere in this book that if you have the skill and you have someone there that is skillful to be able to complete the procedure and not injure the infant, intubate the trachea and use a meconium aspirator and remove all that crud before they take their very first breath, because once they take that breath, they inhale it, But that's not the case. A lot of times when you have meconium aspiration or distress in utero, or a meconium stained amniotic fluid, it can definitely cause distress. So, like NRP says, you want to have at least 2 qualified people there who can initiate the resuscitation. So 2 people there at least should be able to completely resuscitate the infant. That is from scratch to finish, start to finish, right? And that's where the respiratory therapist and the RN comes in, because when you go pick up a baby, a little preemie somewhere, you don't have a neonatologist there, and the pediatrician's not going to get in our way either, so it's us. So, I got to know how to get in their way. I got to know how to manage the vent. We have to know how to give fluids. We have to know how to read an x-ray if there's an emergent crisis where there's a tension pneumo. And I have to know how to recognize that, and I have to decompress that. And there's a lot of other things that I have to do as a respiratory therapist. So I am used to a completely very wide scope of practice. And I can't accept anything less. That's just, maybe this old dog right here, and when I'm on the way out in a year or 2, because I'm, probably going to retire soon, I guess the old dogs, the old horses will be gone. Yeah, but when you get in your 60s and you look back and you see this new generation of neonatal therapists coming out, it's just, they got the bridle on, it's a shame that they cannot function wide open and actually functioned and actually apply what they learned in school. But yeah, so I'm going to read here page 52 right here. This is the 8th edition right here, textbook, Neonatal Resuscitation from the American Heart Association, AAP, American Academy of Pediatrics, and this is what it says. Meconium stained fluid and the vigorous newborn. If the baby is vigorous with a good respiratory effort and muscle tone, the baby may stay with the mother to receive the initial steps of newborn care. Well, you know, old school, if the baby comes out and he's covered with meconium and he's vigorous, you know, I like to clean him up, suction the airway, make sure that he's okay, and then give him back to the mom. But now they have, you know, this delayed cord clamping thing, which is fine. You want to milk that cord and get the nutrients as needed into the baby. So they're not really in a hurry to cut the cord either. But you know, I just don't like it when they delay too much, because I've had a lot of infants end up with meconium aspiration, and they end up with RDS, and then when they end up with this aspiration, they end up with meconium aspiration syndrome, and they end up on a ventilator. And then sometimes the cases that are so bad that we have to give surfactant therapy too, you know? And all that could have been avoided if the airway would have been suctioned properly and quickly without, you know, I've never had an issue with vagal response or damage to the infant. If the therapist or whomever is really skilled in this, they should be allowed to do it. Because if I attend your C-section or delivery, your kid's not going to end up with meconium aspiration syndrome at event, not if I can help it. But that's the way I see it. And then this heading here, meconium stained fluid and a non-vigorous newborn. Listen to this, if a baby is born through meconium stained amniotic fluid and has depressed respirations or poor muscle tone, bring the baby to the radiant warmer and perform the initial steps of the newborn care as described in this lesson. You will use a bulb syringe to clear secretion from the mouth and nose. Well, a bulb syringe is okay, but if you have thick particulate meconium, it's not going to do squat, all right? So that's why I missed the DeLee. And the DeLee is a type of device that, and it has a little canister there, and if you know how to use a DeLee, you're not going to injure the infant. And not only does it suction thick particulate meconium out, you can measure it. You know, the other day I sucked out 40 mLs, 40 cc's of thick meconium. Cleaned this kid's clock before he had, you know, a chance to inhale this stuff, and everything went just fine, you know, and the kid did not end up on the ventilator with meconium aspiration syndrome. But you will use a bulb syringe to clear secretions from the mouth and nose, okay? So this is the AAP law. This is what you got to do now. If the baby is not breathing, or if the baby is breathing and the heart rate is less than 100 after the initial steps are completed, proceed with positive pressure ventilation. That's one of my pet peeves that really aggravates me to know that. So now we got a kid here who's non-vigorous. They don't want you to suction the airway properly, as I'm used to doing. And now if the heart rate's less than 100, okay, instead of intubating very quickly, cleaning the kid out within 5 to 10 seconds very quickly with no problem, using an endotracheal tube, going below the cords, now they want you to positive pressure. So you positive pressure the baby, and now we're slamming the meconium into the lungs, into the alveoli. Enough said on that. Seriously, I'll take on anybody with that. I don't care who you are. You know, it just doesn't set right with me. So, you know, if my heart rate starts going down, and it's not going to be going down because now I've seen people positive pressure the ventilation. They panic. The heart rate starts going down. Oh, let's start positive pressure immediately. I've even seen them start compressions. You know. And keep in mind, the number one cause for bradycardia on a kid is going to be oxygenation, you know, secondary to airway. You have to have a clear airway on these infants. Now, if you're not an expert at intubation and assessment, then don't attempt any of this. Now, I'm going to strictly follow the NRP guidelines because I teach it. I'm an instructor, and that's the way I'm going to teach it. But I'm just telling you, old school. That's not the way it used to be. So I'm beginning to see now many infants end up on ventilators because, you know, they're not allowed to suction the airway, or they get written up for suctioning the airway with a vigorous infant that's, you know, and lots of times, if the infant's covered with meconium, and, you know, at birth and the kid's already crying, then, okay, I understand that, but I'm still going to suction. And you can feel the fremitus, you know, you can put your hand on their chest and feel the vibrations. I've had infants many times that have poor saturation levels and all, you know, not these little ones, you know, but turn them from side to side, do a little chest physiotherapy, suction, clean, little side to side, side to side, give them a little CPAP, you know. The last thing that I want to do is give a meconium baby positive pressure or CPAP until I clear out the poop. I mean, that's just the bottom line. Yeah, so, you know, I've got my own statistics where I've done, you know, hundreds of kids, and a super high percentage of these end up on ventilators or on non-invasive CPAP because of meconium aspiration. That could have been prevented. So that's just my beef. But we're going to follow the NRP guidelines, you know. I kind of wish they would use respiratory therapists, you know, as a guide, you know, to their statistics. So, yeah. So here we go. So if a baby's not breathing, this is a non-vigorous meconium stained fluid. Not breathing, or if the baby is breathing and the heart rate is less than 100 beats per minute after the initial steps are completed, proceed with positive pressure. Routine laryngoscopy with or without intubation for tracheal suction is not suggested. It says not suggested, but it doesn't say it's contraindicated. So it's suggested. I'm interpreting that as if you can do it, do it. You know, it's not suggested. You know, just like ACLS, we're not in a hurry to get people intubated because the morbidity rate goes higher because people don't have the skill to intubate while compressions are being done. I understand that. You just scope the patient, you say, stop, I can't intubate while you're doing compressions, you know, even with a glidoscope. Well, if you don't have the skill to do that while you're doing compressions, then why are we at the head of the bed? You know, let somebody else do it. You know, I don't have a problem with intubating people, whatever's going on, or compressions or not. That's what I'm supposed to do, and that's what I've learned to do, and that's what a respiratory therapist that attends. If an RT gets at the head of the bed, please know what you're doing. You know, and don't waste time. Get the patient intubated if you can't. Let the physician do it. But I'm straight down the lane, man. You know, I don't mess around. Hang on. Yes. So yes, and then the last thing I'll read here is, you know, again, I'll read that sentence. Routine laryngoscopy with or without intubation for tracheal suctioning is not suggested. So historically, routine intubation and suction immediately after birth was recommended in an effort to reduce the chance of developing meconium aspiration syndrome. However, recent systemic review found no evidence to support this practice. Intubation and tracheal suction may be necessary. The positive pressure does not inflate the lung and airway obstruction is suspected. Over the past 40 years, I've had a lot of obstruction from meconium. And if I had not intubated the trachea quickly within those 10 or 15 seconds, the infant would have probably not made it, or would have ended up on long-term mechanical ventilation. So that is something to think about. In the meantime, follow the NRP guidelines, study your stuff, know your stuff, and soon I'll be going over full resuscitation for infants, for preemies, and for pediatrics too. We're going to talk about everything you can think of, everything that is in the book, everything from fluids, all fluids we will cover. We will cover the reading and x-ray management, and also pressors. We will cover all the pressors, and we'll go through everything that is done for sepsis, and we'll diagnose and talk about upper and lower airway issues also. All right, I hope everybody enjoyed that. I'll see everyone soon.